I'm just going to be a coordinator.
All right, let's come back together, please. We have, there's no rest for the wicked, and we are going to work over lunch. We're fortunate to be able to do that, and we're fortunate to have Dr. Bill Pierscala with us. He is a Distinguished Professor Emeritus of Decisions, Operations, and Technology Management in the Anderson School of Management at UCLA. He's also the Ronald Rosenfeld Professor Emeritus at the Wharton School, was Dean of the Anderson Graduate School of Management at UCLA as well. He holds a degree in economics and an MBA from Harvard, and an MA in mathematics from the University of Pittsburgh, and an MS in statistics, and a PhD in operations research from Stanford. So Bill has the total pedigree, East Coast and West Coast. But most importantly, his interests include operations research, operations management, issues of global competition, and the management and delivery aspects of healthcare delivery. And that's really what this work's all about. We're fortunate to have him here with us. He's going to lead us through, I think, an important discussion. It will go, he tells me, where we take it as a group. But I think this will help us chart our path and potentially a roadmap for the next year. So, Dr. Pierscala, thank you.
Well, thank you very much, Gary. Appreciate the introduction, and I think we better get started. Just to give you a little background of a few things I've done in healthcare, I want to start off with a disclaimer also. I am not an expert in scheduling, especially not in patient scheduling. However, I have done quite a bit of scheduling. I've done nurse scheduling in large medical centers, scheduling transportation vehicles in blood banking and in regional blood operations, and some scheduling of physicians through medical centers and medical schools and their educational process and the residencies and fellowships. And I guess about the only other scheduling thing I might mention, I've had interactions in hospitals with scheduling. Not so much with patients, but with the ancillary and supportive services in hospitals. And I've always found it surprising that when we talk about scheduling patients, we don't think about all these supportive services and ancillary services that much. It tends to be more the clinician side of the focus. And yet, many times I've seen real dysfunctionality happen because the meals aren't done properly or the transport isn't available properly. And it sort of destroys some of the really nice scheduling we try to put into the patient-clinician relationship in large medical centers mostly. Not so much the physician office, the physician practice. That's a little bit different. But so there are a lot of things that we could talk about. We probably won't have time to talk about, I'm sure, because I want to get to a roadmap. They've asked me to help bring us to a roadmap, short-term roadmap of what we should be doing to fix some of these problems that we see and we talked about all morning in the scheduling issues. So to start that off, we're going to talk about what are our choices of measures and processes and improvement that we can begin with in a short term to make a change happen in our institutions. And in looking at that and thinking about that a little bit, we'd mentioned sometimes that these are really, a lot of these are problems of queuing. Now, queuing is a very big subject and rather arcane, but it really consists of a simple process. There's an arrival process, a waiting process, and a service process. Now, and if you think of it sort of simply that way, you might be able to think about ways of trying to improve it more easily. But when you think of it in terms of this huge network of queues that flow in a hospital, and there's a queue everywhere in a hospital, everywhere. I mean, no matter any place you go, there's a queue of some kind. It might not be a patient queue. It could be a equipment queue. It could be a whole bunch of other things. Nursing queue, doctor queue. But there's always queues. So this interrelated process, how can you tackle it? Well, there's those three pieces: arrival, waiting, and service. The arrival process is a matter of controlling that arrival process in some efficient way. Scheduling is one way to start to control that process. But if you dig deeper into the arrival process, there's usually quite often, very often, many different types of arrivals. There's, the emergent arrival, the urgent arrival, the scheduled arrival. All of these interact and cause some kind of issues and problems, especially when they compound it by coming at the same time or unexpectedly. In the waiting process, we talked a lot about that this morning. How do you either reduce it? How do you eliminate it? How do you change it? Or how do you manage it? Managing it is what we talked about quite often. If you wait an hour, but the communication is good, or you're doing something that's constructive and adds value, it's a lot less. The part we didn't talk about, and I'd like people to think about this, is we talked about sort of the measures of the waiting time or the waiting process. But what about the measures of the outcomes of that waiting process? After you've gone through it and you've seen it, and then you come out of it and you say, have they met my expectations? What did I think I would wanted to get out of it? And did they meet my expectations when I got out? If those expectations are met, the waiting for an hour or the 2 hours is forgotten, often forgotten. On the other hand, if they're not met, it all seems worse along the whole process. So in terms of measures, I think we shouldn't just look at the sort of the waiting areas or the scheduling issues, but what is the expectation of the patient through your system, and how to get at that. And finally, then there's a service side. The service side of a queue is, how do you fix that? Well, I heard from Cincinnati, if you don't have enough people, you can add people. If you don't have enough operating rooms, you can add operating rooms. Frequently, that's not the right answer. The frequently right answer is you look at the processes, you do flow charting of your processes, you look at causal factors that may or may not, that may be causing your problems, such as using a fishbone type diagram or something of that type, and you start to analyze, and quite often, it isn't a matter of adding people, it's a matter of improving the process. And because technology and people and knowledge keep changing, that's a continuous operation, because anytime you fix a process, it's broken in a month or 5 months or a year, because all kinds of things have changed. So it's a continuous activity. Enough of my little lecturing. I think we now want to get to knowledge that you can help us in this particular study. One of the things that this committee is concerned with is, what are some initial practical steps that we can recommend to improve the flow of patients through your system, whether it's a clinic, whether it's a hospital, whether it's any type of healthcare encounter? What are some of the initial steps we can take to improve this process? We know we don't have enough data. We don't understand the system well enough to affect major change in the short run. But what are some of the things that might be able to be done for an organization to begin to make improvements in their processes? Anybody have any ideas on that? Because this is one of the problems. See, all of you come from places where they're really doing wonderful things, to tell you the truth. I go to the Mayo Clinic, that's my hospital. They're doing wonderful things. I can see lots of things they could change to improve things, but they're still really doing a good job. And many of you are. And we're hearing all these success stories. But there are a lot of places that have a problem. When you go into a small clinical practice, 2 or 3 physicians, 1 physician, and you expect them to start to try to improve or change their scheduling system, or to hire a nurse practitioner to interact between the physician and the patient because the physician doesn't have enough time to be able to do that and still be able to make a living. All of these things are a problem, and how do we start to, where can we start for a lot of these places? David?
I have a kind of a preliminary comment before that, which will be obvious once I've said it, which is whatever you do and however you start, make sure patients are engaged in your process.
Good point. Back there first.
Mike Davies from the VA. One of the things we struggle with is we don't know where we sit compared to you all, because we know our own internal data and the way we do it, but I don't know. The only study that I know of that we really rely on is MGMA, which does these surveys, once every couple of years in a few cities. But I would argue that, one place to start would be to figure out a way to all get on the same page with understanding our access measure.
Okay. Yes. Sure.
Hi, so I'm Jackie Griffin. I'm an assistant professor at Northeastern University. And what I've seen in a lot of the healthcare settings I've worked in is trying to increase flexibility or look at ways we can use resources more flexibly. So rather than dedicating specific rooms to specific physicians, we often see that if we're able to kind of share some resources, whether it be medical assistants or whether it be rooms, we're often able to see the entire flow of the process go by better, and we can actually incorporate that when we're thinking about scheduling as well.
Yes.
Christy from Press Ganey. I'm interested in any experience anybody has in the room around the integrated practice units, like Michael Porter has talked about, MD Anderson's Head and Neck Cancer Center, in the reduction of waiting time and improvement in patient experience. So I'd be interested in thoughts about that, because it seems to have potential.
Hi, I'm Mike Deneen from the Military Health System. We had a quite effective partnership with MIT and the Lean Advancement Institute for 5 years to create a system of care for behavioral health. And in that work, we found that, for instance, the third available appointment, we were focusing very heavily on first appointments. And what we found in the system analysis was what that gave rise to was a perverse incentive to get people in once, but then not follow up with them. And so the system analysis allowed us to see that you need measures throughout a value stream. So I was relating very much to what we were hearing from ThedaCare. But in the end, we were able to show that if you manage the whole value stream as opposed to one piece of it, you can get major improvements, and you can also avoid a lot of unintended consequences. But the other thing we learned from it is from the beginning of this to the end took 5 years for that one, and it's very much in its infancy. And as you just said, the processes we fixed 2 years ago are having to be fixed again. So it's not as if you fix it once and it's done. And even so, we're humbled to know that although there are improvements in our behavioral health system, there are much, much more to go. Thank you.
There's a hand over there. Well, one thing I've noticed when I've gone into medical centers, mostly, not physician offices, and I have a student team usually. It's usually in conjunction with something I'm teaching or doing or whatever. The first thing I ask my students to do is to try to really find out what are the problems being faced by whoever we're working with, whatever group, radiology, laboratory, pharmacy, whatever. What kind of problems do they see? Then I ask them to try to do what I call, you probably know them, fishbone diagram or Ishikawa diagram, simple things, very simple, and say, what could be possible causes of this problem? What are the nature of what are the causes? Are there people, are there technology, are there flows, are there processes, what are they? Another thing then I'd ask them to do is to start doing flow diagrams or flow charting. What is really going on in the process? After that, then go back and talk to all the people involved in this whole thing, as well as the interconnected people, because there's a lot of people that are interconnected, because it's a system, it's a network, things are going on, and start talking to them about what is there. It's amazing how quickly, very quickly, we get to understand what the problems and issues might be, start to understand where the causes might be, start to understand how to look at that system or that network, and then start to tackle the problem. And you can make fairly good progress, I think, fairly quickly, doing simple things like that. On the other hand, we've gone in and, my work in nurse scheduling took years. And we had it running in all kinds of major medical centers in the country. But as soon as the company that I sold it to merged with another company, and the other company was less interested in doing it and didn't maintain it, it was obsolete in 12 months. So it was gone. Basically, 12 hospitals using it, running, very comfortable with it. And in fact, it was working so well that the nurses were starting to game it pretty effectively. So you have to keep on top of that, too. But then it was gone. It was gone because it wasn't maintained. It just crashed. So there are years involved in some things, too. Yeah.
Mark
Go ahead.
Allen from
Yes,
Theta
sir.
Care. My thought to your question is really a combination of measuring performance, making it transparent, and ideally in an area that is unassailable from a cultural standpoint, patient safety, for example, because nothing happens unless we get past the delusions of excellence and delusions of world-class care that we all believe we're actually delivering, because nothing will change unless we can depower that.
A very good comment. Yes, that did.
Hi, Peter Pronos from Johns Hopkins. My sense is we might also be well served by thinking, and I'm out of my box because I'm not a systems engineer, but what's the purpose of the visit? We act as if the visit is the goal, but that by no means is the goal. The goal might be information, it's to have something done. There's a variety of different ways, and I think if we can clarify the purpose, it might help inform a measurement system.
Mm-hmm. Good point. Okay, one more, and then we'll move on to another more, I would say, pithy topic. Okay.
Alexa Kimball from Mass General. One of the interesting things is a disconnect that we're going to have to also address, I think, to solve this. And that is that referring physicians and patients typically think that a wait for a routine visit of 2 to 3 weeks, for example, is about the time frame they'd expect. If you ask receiving physicians what they think is an appropriate amount of wait, and clinically relevant amount of wait, oftentimes it's a lot longer. So it makes it a very difficult conversation to say people want to see you so much faster when you don't feel the clinical urgency of the safety issue as was posed. So we're going to have to square that, I think, in order to bring those two together.
Mm-hmm. Let's move on to another item on the agenda that we should try to bring some ideas to. What kind of measures should we be doing? One of the things you teach in a business school is if you don't measure it, it doesn't change. And that's a true statement. If you don't measure it, it doesn't change. What are some of the measures we should really be thinking about in this whole scheduling arena that will help bring about the kind of change we would like to see? And we heard about some very interesting ones this morning. I was very impressed with Children's, how they measured a lot of stuff, brought it to the physicians, and it changed behavior. It does change behavior. So what measures should we be thinking about here? Yes, sir.
Could I just say one thing, a follow-up on that that comment about the doctors thinking it needs to be this long for clinical reasons and the patient thinking it needs to be quicker, I think that's a limited idea of what's clinically relevant. That if the patient is very scared about something, then it's clinically important to see them or to at least understand what they're scared about. And for doctors to say they can wait longer because it's not clinically necessary for a safety reason to treat whatever the underlying cause is, that's ignoring that it's a big part of clinical relevance to manage the pain and anxiety the patient feels. And I think we have to address that up front with our doctors.
That's exactly the point, is that you've got to bring the doctors around to this idea when they don't see the option.
Yeah. Reminds me of the stories you hear about, well, the patient came in, I couldn't do anything about it because he just have to wait because it'll basically cure itself, but I'll give you these pills and go home and you know, basically placebo-type pills, but they're much happier, much happier. Yes, sir.
Yeah, Mark Murray. You asked about recommendations for waiting times. And I think it's important to categorize what we're looking at. There's a difference between the waiting time for an appointment and the waiting time at the appointment. And you addressed the waiting time at the appointment with the arrival process, the middle process, and the discharge process. There's also the delays for the visit. The best way to measure that is third next available. And the reason for that is that what we're measuring is not an actual wait, but what we're measuring is the capability of that system to deliver. And so as Lisa mentioned earlier, she said there are some patients that would like to get an appointment in 2 weeks. Well, true. And there's some people that want an appointment in 7 days or whatever. If we measure third next available and we can achieve a short third next available, which we can when supply and demand are matched, when we can do that, then it doesn't matter what they want. We can deliver anything. And that's what we want. We don't want to settle for building a system around those people that want 2 weeks versus those people that want 1 day. No, you build it for the shortest, and then you can deliver the longest. All right, the waiting time at the visit's different. It's basically a lead time or cycle time measure. Check in, check out, step, 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 delay, delay, delay. And that's how we would want to measure work through a hospital as well. The other thing you brought up about measurement about the ancillaries is also critical because, for example, in a hospital or even in an office visit, you can only go as fast as the least constrained step. So if I want to get my patient out of the hospital, the length of stay, the ultimate governor of that is the patient's physiology. We can only go as fast as their physiology, and we have to do things to support, accelerate, and supplement their physiology. So all those other tests and things that we have to apply, those issues, the tests, the discharge planning, the pharmacy, the medications, all that has to be short so that it doesn't affect the length of stay. So cycle time for the visit, cycle time or lead time for the hospital stay, third next available for the delays, the delay for a service, third next available.
Good comments. Yes, yeah.
So for the third next available, my concern with that, and I think we had a number of panelists talk about it, is you have multiple clinic grids, right? So we have one provider who has, say, 7 clinic grids for new patients, for specific, appointment types. And so you could do that measure and it would still not truly tell you the wait time, right? It might seem like the wait time is sooner than what it is, further than what and so I think like some of that we have to understand the context in which we're talking about things, because measuring, right, it's not just that one piece of measurement, but what are all the other things that tell us about access? And in some cases it is, could they see other providers, and not meaning other physicians, but nurse practitioners. And so maybe there's more thoughts about looking at either staffing ratios, understanding getting the patient in without just that when's an appointment open for them. So.
Yes, Pat.
Patty Gabel. I think when we think about measurement, we should think about it in multiple bins. There's measurement in real time of the process that you can use production boards for, that kind of thing that help the workers actually deliver on the process. Then there are measurements that are at a system level, and those I think we have to be very careful about continuing to add more and more measures to that, because as you heard from the VA, suddenly it gets into a congressional law, and it may be the wrong thing. So I think that we can have a lot of measures that are real-time at the process level, but we should really have a paucity of measures that are at the system level so that we aren't killed by this constant propagation of measures that get written into stone, and then when they prove to be bad measures, they're still there.
Well, in your experience as a CEO, what measures would you like to see at the system level?
I don't know the answer to that.
You don't have to answer. That was a cold question.
I mean, access measures, I think, are complicated. I think the third available appointment has become a standard. Obviously, it's not perfect, but it is a measure that is useful, I think. But I think it's more important to have measures at the front line that enable the processes to flow and that are transparent. So, but I think we have to distinguish between those two. I'm sorry, that's not really picking a measure for you. But
It's hard to, Terry, do you have one? No. Back there, yeah, the man.
So the dominant part of the discussion really, I think, has revolved around access in an outpatient context. And I guess what I would suggest as an intensivist, I may be more hospital-centric, but I would suggest it'd be very helpful to dichotomize the metrics and to look to some extent at inpatient issues, because there's an evolving literature, and it's actually a substantial literature that really would force us to say that wait times and delays in care are a quality issue. Recent work would suggest that when a hospital occupancy exceeds 92%, there's attribution for mortality, significant mortality. Wait times for critically ill patients in the emergency department, more than 6 hours, probably an 8 to 10% incremental mortality for that population. So there are a myriad of things that can be done from an operations research perspective in terms of operating room scheduling and looking at how we schedule MRIs, timeliness of therapy, the capacity to really schedule discharging, all of which the failure to do so results in backups in the ED. And I think it really is a quality issue, because fundamentally in the hospital base, beyond patient satisfaction, there's attribution for mortality. And I don't think we ought to lose sight of that, just because that is, from a hospital perspective, just a very, very important part of going forward. Not in any way to speak in a pejorative way of the outpatient and the access and the waits for people with chronic disease. I'm not implying that that's not important, but there are clear studies showing mortality related to the inability to effectively schedule and optimize care in the hospital-based settings.
There's one more back there first, and then I'll come here.
Thank you. Terry Pipe, I'm Dean of the College of Nursing and Health Innovation at Arizona State University. So 2 items that I would look for in a measure. First would be the patient and caregiver experience, and thinking of caregivers where we see patients often in dyads, either probably the bimodal age spectrum, so elderly and children. So looking at a very multidimensional measure of patient caregiver experience. And then secondly, as we're preparing nurses to provide care in interprofessional teams, interdisciplinary teams, allowing some measurement that is very sensitive to team-based care, so waiting times that can help us distinguish the experience going to see one provider versus multiple providers. So thank you.
Yes,
The other thing I think we need to think about in terms of process, and going back to your point with mortality and on the inpatient side, most hospitals are staffing nurses at 12-hour shifts. We know, based on the research, that that's not good for nurses, it's not good for patients, and it's not good for hospitals. And so I think we're going to have to gain some flexibility and creativity in terms of nurse scheduling to be able to address some of the mortality and staffing and access issues.
Okay. Yes, Ava?
So I would like to mention is that when we talk about measures, maybe we talk about performance metrics, and two things I would like it to be, to really focus. One is qualitative, and the other is quantitative. I think these are very important because we cannot just use a number to really represent a performance. There's also the measurement that I think is important is the patient-driven, their perception of like what is really what is from them that they think it is satisfied in terms of the quality of care and the timeliness of care, which is quite different from one unit to another, and I think that's really important. But from the care point of view, I think, for example, if we want to know utilization or productivity of doctors, how busy they are, those are quite easy to measure, right? In a sense, how much time they engage in the patient. So we can measure that. But a doctor could be very busy with patients, but at the same time that the system could be so not efficient, right? So those are kind of an interesting, that's why the system dynamics is so important. And I think we cannot really forget that. I think all of these parts are really interdependent. And I think as we actually try to come up with metrics, we also want to understand these metrics are also interdependent. Some of them may be conflicting, and some may be actually working towards each other. And I think it is nice to be able to understand the trade-offs and also trying to really drive to the, in some sense, the, like what we say, efficient frontier, right? What is the best, like, all the objectives that we can achieve, understanding that there are some trade-offs at the end. And if that is the case, how can patients accept that, and how do we compromise that and work with the patients so that everybody is happy?
Jim Bennion. Thanks, Mindy. So, Bill, measures are a powerful incentive, as you mentioned. So I wonder if we need to have, I mean, I agree with the comments of some simple management measures and then some local diagnostic and improvement measures as a general rubric. Should we also have some conversation about negative measures? I mean, what gets measured gets done. So are there negative measures in the systems that are encouraging poor access? And I'd love to kind of hear from the systems here, their thoughts on that. I have, you know, if you're going to evaluate me on leakage outside of my system, I'm going to try to keep all the work inside my system. So to what extent do we feel negative measures are an issue?
Everybody hear that? Are there negative measures that we are doing now that we should think about eliminating or at least not adopting?
Warren Sandberg from Vanderbilt. So RVU-based productivity incentives basically incentivize churn, and that in turn might block out new visits. So I would recommend that we look hard at that one. While I have the microphone, though, and if you're asking for a metric, Dr. Kaplan actually alluded to this at the beginning of the second section, that if we focus on single metrics, then we miss the complexity in the system. We may actually sub-optimize the system. So if you're looking for a higher order metric, simply heterogeneity among the various performance metrics that you're looking at might be a signal that you've sub-optimized something. Mm-hmm. So if your outpatient time to third available visit is looking great, but your time to the OR is looking bad, maybe you've actually sub-optimized something in that, and that would be a signal to go look.
Somewhere, yeah. Okay, well, let me just give a couple comments, too. When I did my nurse scheduling, one of the things we really wanted to do, well, there are two conflicting objectives. One is to make sure we have enough coverage on every unit to meet the needs of the patients all the time. The other one was we wanted to make sure the nurses were happy with their schedules and that they had got the kinds of schedules they could live with and, you know, see their family or do whatever they're going to, other activities that they undertake. These trade off a bit. because the best schedules is Monday through Friday and close the place on Saturday and Sunday. That's a little hard. So, and the same thing with night and evening and day shifts. So what we try to do is understand what is the utility function that each nurse had. You know, these are big hospitals. They might have 1,200 nurses. What is their utility function? Well, how do you get at that? Because this is a concept that is more academic than easily implemented sometimes. How do you find this? And we used a simple technique, very simple. We took a pie and said, this is your number of weekends off in the pie. This is your number of consecutive days worked. This is your number of days that you can affect in some other way. And we give them the pie. Now tell us how much of the pie you really like better in each of those categories. That's basically finding a utility function. They're 100% and they have to distribute it. That worked actually very effectively to get the nurses what they really would like to see in schedules. Then we started to build schedules. But what did we look at as a hospital, a systems measurement of whether we were doing good schedules? We looked at turnover. We looked at sick days off. Because a lot of sick days aren't so sick sometimes. Especially if you have a day off, a day on, and a day off. You know, that middle day tends to sometimes be a sick day. And things of that type. And we looked at these sort of outcome measures of, had the satisfaction, we knew that, but then we had to see what we are meeting that. And in fact, the computer, there's so many gazillion possibilities for schedules. I mean, there are trillions. And the computer could find schedules that were far better than any scheduler, human scheduler could do. So we improved across all those things, satisfaction, everything. And then the system went bad. But basically, I guess what I'm talking about is there are schedules. I like the comment, personally, I like the comment about thinking of mortality. You know, one of the things we have in an operating room scheduling is we have bumped patients. We have overtime. We have all these kinds of things. So a schedule should be able to handle measurements like that and say, are we improving things? There's a lot of measures we can do that will lead us to some kind of improvement if we do it properly, including physician satisfaction with the schedules, including patient satisfaction, including all of these. So I just bring that out. Am I running out of time? Pretty close. Let's see what else I've got on my list we should be covering. What kind of people do you need in an institution to do this scheduling? Do you have them? What kind do you need? How many? What have you hired? I happen to know the Mayo Clinic has about 100 people that do systems engineering kinds of stuff. That's a lot of people. And only wealthy places can afford that. But what kind of people do you need, and what kind do you think we should be recommending to these different places and how they should use them effectively to do systems engineering in healthcare? Yes.
I can't claim that what we would do is generalizable, but because we're a large physician group with a bunch of advanced practice nurses as well, we're bigger than many hospitals. There are about 100 anesthesiologists in my department. Our systems engineers are the physicians.
Are what, I'm sorry?
Are the physicians.
Oh, they are? Well, that's terrific.
Right, because we get about 150% of effort out of them.
Mm-hmm. Okay. Anybody else want to tackle that? One of the things I did when I was at the running the Leonard Davis Institute and the healthcare program at Wharton was we really decided we had to have more physicians trained in management practices, whether it's system engineering or a whole bunch of things. So we partnered with the Robert Wood Johnson Clinical Scholars Program, and we had a lot of their scholars in our MBA program and in our courses. Maybe they weren't in the program, but they were in our courses. Then we instituted a couple courses in the medical school curriculum by the physicians who went through our courses, such as clinical decision-making and using decision trees and utility analysis and trying to get at how to change the thinking of people into either a decision framework or a systems-type framework. If we can do things like that, yes. Yeah.
There you go. Thank you for the opportunity to comment on that issue of what is needed for systems engineering. And I think it's not a simple question. It's not a simple answer. We've been offering a one-week course on human factors engineering and patient safety for the past 10 years. We've trained more than 400 people in probably 200, 300 healthcare organizations around this country. I hope that those people are not calling themselves human factors engineers. So, I mean, to train an industrial and systems engineer, and I hope I have the backup of my colleagues here at the table, I mean, you need to get a bachelor degree, and sometimes you might need to get a master's degree. In human factors, most people who do human factors get an additional master's. So I think we got to figure out how to do that. And I'm not exactly sure what's the solution, because I think the comment about I mean, we're not training enough people for all of you to hire them. So we need to figure out how do we set up a system so maybe the physicians and nurses are going to pick that up. Maybe the scheduler, the checkout person, the receptionist may be picking up some of these skills and knowledge. And so again, it's not an issue of just taking a couple of courses and moving forward. There's still a lot of technical expertise that may be needed to solve some of these problems. But I really like the comment that you made about changing the mental model of thinking like a system person. I think is really important. Does that mean that you have all of the tools and the skills that you need to actually do the hard work or the technical work of system engineering? Probably not, but that's a good beginning. And we'd be more than happy to work with all of you in the room to try to figure out what would be the system that would help the country, the healthcare industry in this country to really adopt and use more systems engineering that we can afford. We cannot afford to train all of those people that you need.
I hope we don't try that. Thank you.
Thank you very much.